Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to The Deep Dive, the place where we cut through the noise to deliver critical clinical insights straight from the source guidelines and major studies.
Great to be here.
Today, we're tackling a really persistent challenge in acute care. It's how to manage acute cholecystitis in a patient who is, well, just too unstable for the gold standard operation.
It's such a delicate balancing act, You have a patient with, say, advanced heart disease, maybe respiratory failure, or they're already septic.
Right.
And that makes them a prohibitive surgical risk. So you need an effective but lower impact intervention, and you need it now.
And that's our focus today. We're doing a deep dive into two procedures whose names I think cause a lot of confusion.
Oh, absolutely. Especially for anyone new to biliary management.
Cholecystostomy and Cholecystogram. We're going to sort through the current clinical guidelines, including major frameworks like the Tokyo guidelines.
Mm-hmm.
The goal is to give you a concise, really actionable understanding of their specific roles, their indications, and most importantly, how profoundly different they are.
Yeah, the distinction couldn't be starker, really. One is an invasive therapeutic procedure. It's designed to save a critically ill patient's life, right now.
The other?
The other is a non-invasive diagnostic tool. It's often used to assess function in a much more stable patient. So mixing them up can lead to some pretty significant management errors.
Absolutely. And before we really get into the weeds of when and why you choose one over the other, we have to give our mandatory reminder
Always.
to everyone listening, especially those involved in patient care. This deep dive is for reference only.
You must always follow the local guidelines and protocols established in your own institutions.
That is the standard of care.
Exactly.
Okay, let's unpack this. We'll start with the intervention that's often required in the most high-stakes, acute scenarios. Cholecystostomy.
The drainage procedure.
Right. It's therapeutic drainage, almost always done percutaneously. So a needle and catheter go through the skin, through the liver, and directly into the gallbladder.
Usually under ultrasound or CT guidance.
So tell us, who is the ideal candidate? Or maybe a better word is the precarious candidate for this procedure?
Well, we reserve percutaneous cholecystostomy, or PC, for patients with acute cholecystitis who are poor surgical candidates. And we should be specific about what poor surgical candidate really means.
Okay.
We're talking about patients who are often ASA class 3 or 5.
Okay.
So these are individuals with severe systemic disease.
Like a recent heart attack.
Exactly. A recent MI, decompensated heart failure, maybe severe coagulopathy. They simply can't tolerate general anesthesia or the physiological stress of an immediate cholecystectomy.
So it's their systemic instability that's the main driver. It's not just about how bad the gallbladder looks on a CT scan.
Precisely. The goal here is pure damage control. With acute cholecystitis, you have all this pressure building inside an infected gallbladder. That pressure causes ischemia, which can lead to perforation and, of course, systemic sepsis. A cholecystostomy tube immediately relieves that pressure. It drains the infected bile and stabilizes that local infection.
And that brings us to the really crucial part, the specific indications. When do you say, okay, medical management has failed, we need to put in a PC tube?
The clinical triggers are pretty severe, and they're often time-sensitive. The first is, just as you said, failure of intensive medical therapy.
Meaning antibiotics aren't working.
Right. The patient is still septic or just not improving after 24, maybe 48 hours of broad-spectrum antibiotics and supportive care. The second big one is severe disease that meets criteria like the Tokyo guidelines stage 3.
Okay, let's pause on that. Stage 3. For anyone who isn't familiar with those specific TG definitions, what does stage 3 mean that makes PC an immediate thought?
Stage 3, acute cholecystitis, means you have the local inflammation plus definite organ dysfunction.
So it's gone systemic.
It's gone systemic. We're talking about confusion, respiratory distress that needs a ventilator, acute kidney failure, or circulatory collapse requiring vasopressors. When a patient is that sick, immediate surgery is often lethal. So the PC offers quick local source control, but without exposing that incredibly fragile patient to the stresses of the operating room.
That makes perfect sense.
Yeah.
It's a tool for the highest risk group. Are there other scenarios?
Yeah, you might use it proactively if a patient presents with clear signs of sepsis, or if imaging suggests the gallbladder is about to perforate or is already gangrenous.
Okay.
And another one, if you have a biliary obstruction, from a tumor or something else and you can't get access with any RCP, a PC can be an alternative drainage route. But its main job is really as a temporizing measure.
A bridge to surgery.
A bridge to surgery. It lets you optimize everything, their heart, their lungs, their kidneys, before you schedule a much lower risk elective laparoscopic cholecystectomy weeks or even months down the line.
What's fascinating here, then, is that the procedure is almost defined by the patient's systemic instability. It's a harm reduction tool for the most compromised patients.
Absolutely. Think of it like hitting the pause button on that septic cascade. You stabilize the battlefield before you commit them to a major physiological battle.
So let's talk about the evidence. I mean, beyond just avoiding immediate death in a critically ill patient, what are the documented clinical benefits of this?
The benefits are pretty substantial, and the evidence is quite robust. First, you see rapid clinical improvement. That decompression, the drainage of infected bile, it leads to prompt resolution of their systemic symptoms.
And the procedure itself, is it reliable?
The technical success rates are very high. We're talking upwards of 95%. And really importantly for this group, the complication rates, things like bleeding or a bile leak, are low when it's done under imaging guidance.
I have to think that the ability to do this safely, at the bedside without general anesthesia, must be the single biggest factor here.
It is the defining safety feature. And when you look at the outcome data, now some studies show no significant difference in overall mortality compared to just continuing with aggressive medical management.
That's an important caveat.
It is, but you have to remember, you're comparing two different approaches in a group of patients who are already extremely sick. What the PC procedure does do, demonstrably, is improve clinical scores, reduce pain, and control the source of sepsis.
So even if the ultimate mortality risk is still high because of all their other problems, just reducing that morbidity is a huge win.
Exactly. You're converting a surgical emergency into a planned elective procedure for later. But, and this is a big but, we have to stress that operational point. If that patient isn't eventually transitioned to a definitive surgery, they can end up with higher rates of recurrence.
And more hospital visits.
And significantly higher healthcare utilization over time. Tube management, repeat infections. They often end up needing surgery anyway, just under worse circumstances. The PC is a bridge, not a final destination whenever possible.
That's a critical piece of data for hospital systems to think about when they're planning that post-acute care phase.
For sure.
Okay, let's completely pivot our discussion, but stay with the gallbladder. We've talked about the emergent therapeutic stabilization with cholecystostomy. Now let's look at a procedure used for meticulous diagnosis, often in a chronic setting that sounds similar but is totally different. The cholecystogram.
Right, the cholecystogram. This is purely diagnostic. We're moving from therapeutic drainage to detailed imaging.
How does it work?
It uses contrast agents, which you either swallow for an oral cholecystogram or get injected for an IV one, and then you take a series of x-rays. The whole point is to assess the anatomy and, crucially, the function of the biliary tract.
And here's where it gets really interesting for me. Why would a doctor still use this, given how prevalent and, frankly, amazing modern imaging is? High-resolution ultrasound, CT, MRCP.
That is the central question. Because for the initial diagnosis of acute cholecystitis, looking for gallstones, ultrasound has absolutely 100% supplanted the cholecystogram.
So it has a niche.
It has a very important specialized niche, and that niche is functional assessment.
Functional assessment. Okay, break that down for us. What kind of problem can only be solved with that functional view?
It's mainly used when you're working up chronic, unexplained right upper quadrant pain, often when there are no gallstones on the ultrasound.
Ah, so the patient feels real pain, but the imaging looks normal.
Exactly. We're talking about suspected gallbladder dyskinesia or chronic acalculous cholecystitis. In these cases, the anatomy on the ultrasound looks fine, but the gallbladder itself just isn't working correctly.
So structurally it's okay, but physiologically it's misfiring.
You've got it. The oral cholecystogram, or OCG, gives us a non-invasive way to measure something called the gallbladder ejection fraction, or GBEF.
How does that work?
The patient ingests the contrast, their liver processes it, and the gallbladder concentrates it. Then you give the patient a fatty meal, or an injection of CCK, and take more x-rays to see how much the gallbladder contracts and empties.
And what are you looking for?
If that ejection fraction is pathologically low, let's say below 35%, that strongly indicates biliary dyskinesia. And that finding can guide the decision for an elective cholecystectomy, even when there are no stones.
That makes the clinical relevance crystal clear. It's for a very specific subset of patients that modern structural imaging just can't fully characterize. Are there other indications?
Sure. Beyond dyskinesia, it can be useful for looking at complex biliary anatomy or if the ultrasound results are just inconclusive.
I see.
For instance, if you suspect there's a block in bile flow or you're tracking gallbladder polyps, if the gallbladder just doesn't show up at all after you give the contrast, that's a very powerful sign of a cystic duct obstruction.
So while it might be seen as an older technology, it still gives you that critical physiological data point, that functional contractility that a static ultrasound image just can't provide.
That's it, exactly. It has its limitations, of course, which is why it isn't first line. It uses contrast, so there are allergy risks, and the patient needs decent liver function. But when you need that detailed functional data, especially in a chronic pain workup, it's still a really robust tool.
That just perfectly synthesizes the core distinction for everyone listening. So let's just bring it all back together. Cholecystostomy, an essential, often life-saving intervention focused on safe bedside drainage and decompression for the critically ill patient who can't handle an operation.
It's an acute therapeutic maneuver, while the cholecystogram is all about non-invasive imaging and functional assessment, a niche but valuable diagnostic tool for when routine imaging isn't enough.
Usually in a chronic setting.
Usually in a chronic elective setting.
So we've established cholecystostomy is absolutely essential in the emergency, temporary management of these unfit surgical candidates. It buys time. And the cholecystogram, while not first line, is a key tool for specialized functional diagnosis.
Indeed. And maybe as a final thought for our listeners, particularly the surgeons and hospitalists involved in this transition of care, I want to leave you with a provocative question to consider.
Okay.
Given that the definitive treatment after a PC is almost always an elective lap call, what clinical factors, beyond just simple symptom resolution, are the most reliable indicators that your patient is truly optimized and ready for that definitive step?
That's a great question, because feeling better isn't always the whole story.
Exactly. Are you looking for normalization of SIRS criteria, complete resolution of their white count, a sustained period of being able to eat? That careful risk stratification is what really defines successful patient management in the long run.
A question that really requires integrating all of the patient's underlying issues with their acute recovery. A perfect point to end on.
Mm-hmm.
If you found this deep dive useful, please don't forget to share it with at least one of your colleagues or friends. Help spread this knowledge. And also, check out our YouTube channel and other social media pages for more in-depth content. We'll see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.